Hello and welcome to our event. My name is Cheryl Wapes'a Mayes and I am an enrolled member of the Assiniboine Sioux Tribe at Fort Peck Reservation in northeastern Montana. I serve on the organizing and steering committees of Healthcare is a Human Right. I also serve on the national board of the National Organization for Women, and I am a board member of Washington State Now and the president of Tacoma Now, a contributing sponsor of Healthcare is a Human Right. Welcome to this very important event.
Thanks, Cheryl. This is Margaret Cary here. So excited to see everyone here. I am on the steering committee of Healthcare is a Human Right. I am with Working Families Party Washington and Seattle Indivisible.
Our coalition is spread out around the state of Washington. We ask for those engaging in this event to reflect on the lands on which we reside and acknowledge all of the ancestral homelands and traditional territories of Indigenous peoples who have been here since time immemorial. The Healthcare is a Human Right acknowledges the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot nations. Acknowledging the ceded and unceded land on which we all stand could not be more important in our current historical moment. We encourage you to consult land.codeforanchorage.org website, where you can enter in your zip code and see which tribal land you are on. The slides include 29 federally recognized tribes, and note the tribes currently without federal recognition and tribes with ceded land in Washington state. Duwamish, Wanapum, not pictured, Chinook, Coeur d'Alene, Nez Perce, Umatilla Confederated, and Warm Springs Confederated. Regardless of their status, their stewardship of the land remains important and should be recognized.
Thank you, Cheryl. I'm going to move into just talking for a moment about Healthcare is a Human Right Coalition. And as Cheryl mentioned, we're statewide. We are a community labor campaign to make healthcare a right for all people in our state and in our country. And we are part of a growing movement for healthcare justice. We believe that the fundamentals of our healthcare system must be built around delivering healthcare to everyone in our country in an equitable way. And we want to see healthcare for people, not profits. Because how do you put a dollar bill on somebody's life? We are here to talk about transforming the system so it will meet the unique needs and healthcare risks of every human being with no barriers of entry. And as we know, based on our last year, the need for healthcare justice is greater than ever. This pandemic has laid bare the disparities in our system and shown how our health is interconnected among all of us, and how access to healthcare is shamefully unequal, depending on your race, occupation, where you live, and other factors. We in Healthcare is a Human Right are building a grassroots labor and community support for the most effective and economic solution. And we want to see a universal public plan, publicly funded and administered. And what that means is expanded and improved Medicare for all. Finally, we're here today to focus on two things: getting Congress to expand Medicare by lowering the eligibility age, improving benefits, and dropping the price for prescription drugs. Second, we need Congress to expand access to universal health care by giving states the federal support to create universal public plans as provided for there's a bill called the State Basic Universal Health Care Act, HR 3775. And we'll be hearing more about this by one of our speakers to be announced presently.
Thank you so much for that information, Margaret. I'm happy to introduce Sam Hatzenbeler. Sam is the Health Policy Associate in the Economic Opportunity Institute and Healthcare as a Human Right, Washington Policy Committee Co-Chair. It is great to have you here.
Thank you, Cheryl. Glad to be here. I'll go over our goals guiding our work and then jump into talking about some amazing wins from this past session here in our state. So our goals for Healthcare as a Human Right campaign, to piggyback off of what Margaret was saying, we want to advance universal health care at the state and federal levels. We want to improve affordability and access to health insurance and health care. We want to advance racial equity and address disparities. And we also want to protect the critical programs and safety nets that we have now. So these are the policy priorities we adopted for our state level work back in December to guide our session work together. We wanted to prevent cuts to healthcare and income support programs. And just to remember back in fall of last year, the revenue forecast was extremely bleak. And so this is a particular perspective that we were taking. We really wanted to make sure that what we have now would be preserved, and but also, you know, as time went on, we our state budget made it into the black, as they say, and we also got incredible federal funding to support local and state government programs in the recession. So we were able to continue to push for larger wins as well, including pressing for progressive revenue, making sure that the programs that are so important to our state are not funded off the backs of low-income people, and that we can address our state's regressive tax system. And also a number of bills that we actually made progress on every single one of them, which is absolutely phenomenal. And just huge thanks to everyone who fought so hard this past session in terms of improving affordability and access to care. Here's a list, but I'll get into each of these on the next slide when we talk about all of the amazing victories we had. The first there is Senate Bill 5399, and this is being called the country's strongest universal healthcare law. So kudos to all who worked on this. This bill creates a permanent universal healthcare commission that basically helps develop the system, and including the financing system for a state universal healthcare system. And that's getting underway in the coming months. So that's really exciting. And also, the budget was absolutely amazing. People have called it the Oprah budget, like you get a program, you get funding, you get funding. And so we really saw no substantive cuts to health programs in the budget. I'll get into a little bit more in a moment on that. Capital gains tax, people have been working on that for years and years. It's a 7% capital gains tax on capital gains over 250,000. So that is really significant, really helps address our state's regressive tax system. Also passed a bill on health system transparency. This is particular to hospitals. Their reporting is notoriously opaque, and it's very important to increase transparency. Next slide, Kelly, if you will, please. And look at all these wins. We just racked them up. Next one is postpartum coverage, extending that to a year instead of 2 months, what it was before for parents that just gave birth. Increasing access for immigrants, and for a clinic-based grant program to help provide funding to clinics that provide care to people regardless of immigration status, as well as a long-term strategy to ensure that immigrants have coverage and can buy coverage on the exchange by 2024. Additional subsidies on the exchange, both for low-income people in general, but also specific to childcare workers. That's actually starting rapidly here in the next few months, that second one for childcare workers. Dental therapy did not pass, but we did get a task force that will help to expand and take a look at how tribes in the state are using dental therapy to address oral health disparities. So that's still a step forward, even though we didn't get the main bill passed yet. But stay tuned next year. And then 2 bills on mental health, which is fantastic, especially with everything we're seeing with the impacts of the pandemic on folks. 2 of those, one is to create a state office of behavioral health, consumer advocacy, and that's going to regulate and keep an eye on all state level advocacy work for behavioral health. And then also the second bill establishes a 988 crisis hotline, and that will help make sure that people who are in crisis can get next day supports when they're in crisis. Last one, I know we have to move on, is prescription drug access, and this makes sure that we can try to curb out of control drug price for folks and make sure that the state can actually take a more active role in producing, distributing, and purchasing generic drugs, including insulin. So, all right, that is my spiel. Thank you all, and great session.
Thank you, Sam. That was great. At this time, I'm honored to introduce Bevin McLeod, co-founder and president of Alliance for a Healthy Washington. Welcome, Bevin.
Thank you, Cheryl. So for those who don't know who Alliance for a Healthy Washington is, we are a newly formed in 2018 501c4 nonpartisan nonprofit organization that is really working on health systems reform in Washington state. It's not time to go into our organization at the moment, but that's just a brief overall top line. And if anyone's interested in contacting me to learn more later, you're more than welcome to do so. Alliance for Healthy Washington really, looks at this as, how do we get from where we are to a full universal healthcare system at the state level. And so we decided to kind of break it into chunks. And so in 2019, we were able to help author and pass the Pathway to Universal Healthcare work group that we were then able to sit on the work group with many of the folks who are also on this presentation and really put our heads together as to what kind of models could we put forward to the legislature that would get us to universal health care. And so coming out of that commission, we decided to bring another bill forward and get that passed in 2021, and which is standing up the first in the nation permanent universal healthcare system. So really, we are looking to take this chunk by chunk and step by step. So that is, where we are in 2021, is setting up the first ever permanent universal healthcare commission in Washington state. However, in order to get to a truly unified financing system, we're going to need help at the federal level. In order to get the federal government's support, we're going to need waivers, federal waivers. So the State-Based Universal Healthcare Act that Representative Rodke out of California has put forward is going to help us get there. So the commission's tasks really are to look at what we already have, synthesize the information, all of the reports and studies, et cetera, that have already been done at the state level, synthesize that information and turn it into recommendations to the legislature. There are details on the bill. Again, I don't have a lot of time for this presentation that I'd be happy to share with you, and you can find it online as well. But really to say, step 1, this is what we recommend. Step 2, this is what we recommend. And in the process, here's what we can do to get more people covered and begin the journey to a unified financing system. So why is this commission different? There's been a lot of conversation about, we don't need another study. We've already done a lot of studies, which is true. It's very true. There have been a lot of organizations working on this issue for a long time, and many decades, in fact. So it really is not the goal of this commission to do more studies. The goal of the commission really is to synthesize the studies that have already been done and turn that into actionable steps that our legislature can take. Also, I will say that don't know of any other state in the country that has a permanent universal healthcare commission. I think that this demonstrates, a real commitment by the state to get us there. Also, the chair is, has a 3-year term, which I think is really necessary so that it is not really led by a single agency or a single person over time, and that rotates through. There are many different ways in which this commission is different that I don't have time to go into today, but I think that it's an incredibly strong commission. The language in the bill was meant to be incredibly strong. So again, we will see as the governor appoints folks and as the commission begins its work, it's going to be our jobs as advocates and as a community to make sure that the commission is doing the work that it's supposed to be doing. So the big picture, I think you all have kind of heard a little bit already, but really the big picture is, currently any state that wants to innovate must apply for state innovation waivers in Section 1332 of the ACA. That said, even though those waivers technically exist at this time, it is incredibly hard for states to get several of those waivers, and really almost near impossible for a state to currently get an ERISA waiver, which if folks want to know more about what that is, you're welcome to send us an email and ask. But really the big picture is we need Congress. We need Congress to act. We need Congress to make the waiver application process more streamlined and easier for states to access. I'm going to go ahead and push past this slide, but I will say, as the commission does its work, one of the things that we could see as an example is an expansion of Medicaid. Even if we don't make it all the way to a unified financing system in the next year or two, we can always expand programs that already exist. Regional opportunity, yes. There are multiple states in conversation with one another, and under Ro Khanna's bill, the State-Based Universal Healthcare Act, it would allow for multiple states to apply for waivers at the same time. So the answer is yes. Next steps, I think it's pretty simple. Work with the commission, develop proposals, advocate, and that's at every level. That means in Olympia, that means meeting with our legislators, that means building grassroots. And I would say that a really concerted effort at the congressional level to let our delegation know that Rep. Ro Khanna's bill is really crucial, that pieces and components from that bill are absolutely a must for states that are eager and willing and ready to innovate. So you can contact us at allianceforhealthywashington.org. That's my email there. And happy to answer questions via email since we don't have time here.
Okay, thanks, Bevin.
Thank you, Cheryl.
Thanks so much, Bevin. We learned a lot this legislative session about what it takes for grassroots folks to testify and tell their stories, and for the hard work of advocates, sitting through long sessions in Olympia. So thank you, everyone, for the work over the last year. What I'd like to do now is introduce a video. Our representative, Pramila Jayapal, is here via video to call us all to action on healthcare. And thanks to our representative and all of us for our activism to this point. So with that, let's hear from Representative Jayapal.
I'm Congresswoman Pramila Jayapal, and so proud to represent Washington's 7th Congressional District in the U.S. House of Representatives. Thank you to Healthcare is a Human Right Washington for inviting me to share a few words with you today. I'm so excited to join you during today's teach-in on Medicare for All. Long before I ever came to Congress, I was an organizer. So through that lens, let me just say that the work you all are doing to organize and advocate for Medicare for All, to build a powerful movement, really matters. When I reintroduced Medicare for All this year, I was joined by more than half of the Democratic caucus as original co-sponsors, and that included 14 powerful committee chairs and key members of leadership. That progress didn't just happen out of nowhere. While you've advocated on the outside, I've advocated on the inside. And together, we've built a movement to make Medicare for All mainstream and to make guaranteeing healthcare as a human right within reach. We all know the political challenges that exist in making Medicare for All a reality. But I always say that if politics is the art of the possible, then it is our job as progressives, organizers, and activists to push the limits of what is seen as possible. So even as we're actively pushing for Medicare for All, we're also working to implement critical pieces of it right now. We now have more than 150 lawmakers from across the House Democratic Caucus working alongside me, working alongside all of us to urge President Biden to expand Medicare as part of the American Families Plan. That means lowering the eligibility age, covering hearing, vision, and dental, and bringing down the sky-high cost of prescription drugs by finally allowing Medicare to negotiate prices across all payers. We are doing the work that we need to do to make Medicare for All a reality, keeping up that continued drumbeat of advocacy and strategic organizing to finally guarantee healthcare for everyone. We have made enormous progress, and it's because of your work. It's within our reach. So let's keep working hard. I know we will get this done.
Those were wonderful words from Representative Jayapal. And now we're excited to introduce Stephanie Kang, Health Policy Director for Representative Jayapal. She has been instrumental in supporting strategic efforts to move Medicare for All forward. We appreciate you joining us.
Thank you so much for the warm welcome. Hi, everyone. I see Jessica driving and multitasking. Wow, very impressive. Be safe. Thank you so much for having me. And I'm so glad that we were able to at least get the video from the Congresswoman. And she's so appreciative of all the work that you're doing on the ground. And truly, the momentum that she described that we were able to have at the beginning of this Congress, that is because of the grassroots movement we've been able to build. For sure, Senator Sanders was able to really bring Medicare for All up to the national stage, through his presidential runs. But it's the grassroots movement that has really moved the dial on the legislative conversation and political consideration for Medicare for All. And so I'm here today just to give sort of an update. I have a couple slides, but really the slides are just so that we all know what topics I'm talking about. But really just want to talk about giving an update on where we are in Medicare for All. I think it's important for us to reflect on where we've been in order to be thinking about how we're going to move forward. Thinking about what's next. The Congresswoman mentioned, critical foundational policies that we can put in right now that capture tenets of Medicare for All. And that would quite frankly make it easier to move towards a Medicare for All system. And then also just thinking through to other pieces. And so I don't know if I don't have to tell anybody on this call that, this past year has just made the case loud and clear as to why we have to transform our healthcare system, why we have to untether employment from healthcare, and why we have to truly move forward with this movement. And I remember at the beginning of this Congress, and there was a nervousness that was happening because, we have an administration that, thankfully isn't Trump, but still Medicare for All was not a topic that President Biden ran on. He did not support it, and he actually actively opposed it. And so there was a sort of nervousness of how do we then maintain the momentum on Medicare for All and single payer, because we cannot forget that in the last Congress previously, so I started with the Congresswoman in 2019, there was really this just unprecedented moment that was happening in the House of Representatives. We were introducing the bill with lots of support, a bill that was more comprehensive than had ever been introduced before. And we had also gotten congressional hearings on the policy, which meant, and this is really important, I don't know about y'all, but before I started my job, I had never watched C-SPAN or seen congressional hearings. I don't know who spends their time watching that if you're not working there, but if you have seen it, these are really important because basically what it does is it allows Congress members to actually debate the policy. They can participate in a policy conversation And also, it's the first step for legislation to actually be seriously considered. It's the first step for legislation to make it to the floor for a vote. And so, we had 4 congressional hearings. It was really incredible. It was constantly debated on the Democratic primary presidential stage. We saw, just poll after poll, there was this really strong public support. And then COVID came along, and I think just made this case that was so powerful, where when we were starting to whip again for co-sponsors for the Medicare for All bill, you could just see that the conversation had really changed for Congress members, literally the conversation they were having with their constituents. And I remember just very distinctly when we were rolling out the bill, we were adding on members who had never, ever been on a Medicare for All bill previously. Right, that's huge. Again, with the different political dynamics we're going into, the fact that members were now compelled to sign on to a single payer legislation when they had never felt compelled previously was really a signal to us. And some of the reasons I had heard was they were constituents would call and talk to them in their town halls, and they would say, "Look, I can't afford COBRA. I don't qualify for the ACA subsidies. And even if I did, those deductibles are too high for me to afford my care. I don't qualify for Medicaid because my state hasn't expanded Medicaid." All of these reasons, and Congress members just found themselves unable to respond. They didn't have a solution. They didn't have just go do this or this, even though we have so many different programs in our system, right? And so, like the Congresswoman said, I mean, we just introduced the bill with an incredible amount of support. We will only keep adding on support to the bill. We actually just added on our newest co-sponsor, Rep. Zoe Lofgren. So we're at, I believe, 116, which is well over half the Democratic caucus, which is just really incredible. And so what's really important right now is that we continue that conversation that we had. Like I said, we had hearings. We need to make sure that this is part of it. And we have actual commitments on Medicare for All to have full committee hearings in Energy and Commerce. And so Energy and Commerce, for people who don't know, is a very powerful committee in the House. Then basically anything health related, anything Medicare related has to go through this committee. The chairman of the Energy and Commerce Committee, Frank Pallone from New Jersey, became a co-sponsor of Congresswoman Jayapal's bill for the first time and has committed to a hearing. And we've also gotten a commitment for a hearing from Chairwoman Nydia Velázquez in the small business. And so again, this is really about keeping that drumbeat on the inside, making sure it's part of the policy conversation, while also building up the movement. Our movement is growing, the movement is strong, but it's not enough. We're not there yet. The people that we have at the table, we have to expand who they are, where they come from, what communities they represent. We have to start to really make this movement so resilient and so strong that when those political stars align, that we are able to then combat any of the industry talking points, that we're really able to make the case clear for Congress members to make sure this happens. And so while we're getting, that's sort of the long-term strategy, we got to make sure we're building up the movement for Medicare for All, that it's undeniable. While we're doing that, we have to start thinking through what is also possible right now in this moment legislatively, what can become law. And the way that I think about this is, everyone knows here, we have an extremely fragmented, for-profit driven healthcare system, health insurance system. So then what are the ways that we can reduce that profit motive and also reduce the role of private insurance? The more we do that, the less fragmented our system is, the easier it is to then actually channel people into a single program, right? A single program, Medicare. And so when we're thinking through some policies right now, one of the biggest policies that are being talked about, as the Congressman mentioned, is around expanding and improving Medicare right now. Of course, it's not expanding and improving Medicare to everyone, as we would all like. But in this moment, what the Congresswoman was able to get a commitment from President Biden when he was running last summer was for him to lower the eligibility age and to improve the benefits of traditional Medicare. And so this does a few very, very critical things. So if I have any seniors on here who are on Medicare, right when you are turning, you're becoming more elderly, usually you're more prone to suffer certain different health conditions. It's the time where you're going onto Medicare, but right now it doesn't cover dental, vision, and hearing. which is ridiculous. Dental, negative health outcomes are absolutely associated with poor oral health, vision loss, hearing impairments, and it causes just a variety of negative outcomes for depression, dementia, diabetes, risk of falls for our seniors. And it's just simply such an issue, and it's past time really that we cover these. But what it also does is that it reduces the role of Medicare Advantage. What happens right now is that so many, 1/3 of our seniors who are on Medicare are on Medicare Advantage. And that's because Medicare Advantage is one of their only outlets to be able to access some of these services. And it's not like the Medicare Advantage plans are great. Like this, it's very limited on the hearing, very limited on the vision and dental. And so if we're able to then have that covered under traditional Medicare, you're reducing again that role for the need of a Medicare Advantage plan, that private plan. So when we're improving Medicare, I also would really, push for an out-of-pocket cap. It's ridiculous that we don't have an out-of-pocket cap. Medicare Advantage does, ACA plans do, Medicare, traditional Medicare should as well. But when we're thinking about improving the Medicare benefits, we also want to lower the eligibility age. And right now, a particularly vulnerable population is our older adults, our workers 55 and up right now. For the first time ever in the last 50 years, the US Census Bureau has found that those job seekers who are 55 years and older have higher rates of unemployment and higher rates of staying unemployed longer than younger workers. So again, first time in 50 years as a result of the pandemic. And this is really because a lot of these workers had jobs who gave them, decent to good benefits. And now they're trying to go back to the workforce and they're not able to find a job that can match those benefits because guess what? Older workers tend to be more expensive to cover. And the higher costs of employing older workers is enough to keep employers from hiring older workers. And so what we're seeing is that there's this early exit of the labor force that's happening from older workers. They're using up their retirement funds. They're having to go into Social Security early. And this is really just detrimental long-term economically, right? And so, as I said, the president has committed to these in his recent budget proposal. He, again, reinstated his commitment to this and, really pushed Congress. He says Congress needs to take immediate action this year on this. And so our opportunity right now to get these things done is in this infrastructure package that's being debated right now. I'm not sure how well everyone's following that. The Congresswoman has been pretty much every single day in, day out, saying we need to go bold, fast, and big. And enough of these bipartisan talks. We want to make sure that this infrastructure package is comprehensive and that we are thinking of health coverage as a critical part of building out that infrastructure and investing in families. And so, the Congressman mentioned she sent out a letter to the Biden administration. And it's incredible. I mean, really, the allies we have on this, it's not your typical partners. We have Representative Jared Golden, Connor Lamb. We have Haley Stevens, Cindy Axne, all of these frontliners, right? These are people in literally the Trumpiest, most vulnerable districts of the Democratic Party. And they're on the same call with Pramila, with the White House, making the same asks around health policy. This is pretty unprecedented. Health policy tends to be pretty divisive. And so there's really this powerful coalition that's building. And we had, over 150 Democrats on this letter. But we need to make sure it's very clear that this is a top priority. And so, any effort that can go into ensuring that this has a strong support across Democratic members is super critical. And then, of course, in case anyone's curious, this can all be paid for. Last Congress, the House passed HR 3, which is the Lower Drug Prices Now Act, and it was going to produce about $450 billion at least over the next 10 years because it would finally allow Medicare to negotiate drug prices. I'm not sure if people are familiar, but Medicare is the largest purchaser of drugs in the world, and it is literally banned from negotiating drug prices. It's nuts, right? It's crazy. We pay, I think, 3 times more per drugs than the VA and 2 times more than Medicaid. Everyone's heard about how insulin is 10 times more here than Canada. It's ridiculous. It's past time. I don't know if y'all are following Biogen. I'm just kind of going off right now, but I don't know if y'all followed Biogen, but Biogen has a new drug that they claim delays Alzheimer's. But it wasn't endorsed by the FDA's independent expert panel because it had inconclusive data. And do y'all know how much they charged for the list price? $56,000 for this drug. And it's totally legal, and they can do that, even though it hasn't even been endorsed by the expert. It's just crazy. And so if we can finally negotiate drugs, we're going to see huge savings to the system, and those savings could then be used to then expand Medicare so that the cost of Medicare isn't going up, and we can actually fortify the Medicare trust fund for our seniors who are already in it. And so, my last point on that is that, this is just very clear, obvious, good policy. Medicare is one of our oldest, most foundational programs. It just it's common sense really to build on it. But it's also just super popular. A poll came out recently that showed that a majority of Trump voters and a majority in every state across the country supports expanding Medicare. 65% Americans, Democrats, Independents, Republicans support it. And so we just really believe it's, as we're coming out of the COVID-19 pandemic, there's a historic opportunity here. And we really just have to deliver on this and make these critical investments in Medicare in this next package that's going through right now, the American Families and Jobs Plan. But, when we're thinking also just around Medicare for all and Medicare expansion in general, we really have to continue shaping public support. As you all know, that's why you're doing this teach-in, right? Health policy is complicated to talk about. You're talking about the state-based universal healthcare plan, and you're talking about waivers, and like most people are be like, what the heck are waivers? What are you talking about? You have to apply for waivers. All of these things are very convoluted and difficult. And so we have to be really thinking through how are we messaging on these pieces, and what are the different cases that we can make in the really most compelling way. And I think this is something, obviously, the movement has really worked on. I know that this is something that HCHR and others in Washington have really been honing in on. And I think will also be critical for what's going to be coming out of the commission, the Universal Healthcare Commission y'all mentioned. We really need to be thinking through what is the messaging that comes out of the analysis that's produced. That's something that Vermont failed to do. Vermont had a commission. They produced a state-based, it wasn't really single payer, but sort of single pipeline plan, but they didn't think about the way that the public was going to perceive it. And so we want to make sure we're just proactive on that in all levels, federal, state, and local. And then the last piece is really just expanding our stakeholders. Truly, again, the movement has grown to this unprecedented level. It's really incredible to see the way it's grown, but we have to go even further. I believe that there is room for stronger alliances with physicians who we all know physicians have been on the wrong side of history, especially the AMA and AHA, on the wrong side of history for the past century when it comes to healthcare reform. We have to make sure that our business partners are making the case even stronger. We have to be thinking through who are the different stakeholders that we just have not engaged enough in, and bring them to the table and make sure that we have a very diverse coalition here. And so I don't know if anyone's curious, but I just finished my doctorate in public health, and my dissertation was around this. It was really thinking through, reflecting on how did we get here in this past moment that we saw for single payer in the last couple of years, and how do we advance the movement in the 21st century? And so this next slide is really actually directly from my defense. This is literally what I told him. So I told a bunch of my professors, and I'll tell you, Harvard professors tend to be pretty, I know this is recorded, but they tend to be a little bit old school. And I just told them to their face, yes, single payer faces formidable barriers. Absolutely, this is going to be a hard fight. The industry has shown that they're incredibly powerful and effective. But I just truly believe that it'll continue to be offered as a policy solution as long as our US healthcare system is inequitable and is not universal. And so I told them, I said, single payer is not a matter of if, but when. And I truly believe that because of the movement that we're building and that we will continue to build. And so that sort of concludes all of my comments. If there's any questions, I'm happy to answer. I saw the chat was a bit active, but I have not been able to read anything that was going on. And so if there's any other federal updates that you would like about what's happening, either on HR 1976, which is the Medicare for All Act for this Congress, or the efforts that are going on in Medicare expansion, I'm happy to answer.
Thank you so much, Stephanie Kang. So inspiring, your work on a policy level, as well as just your perspective about the importance of grassroots organizing is just fantastic. And congratulations on completing your doctorate, by the way. So we were lucky to have people submit questions in advance. So I'm going to begin with one question, and then Cheryl will add another question. We have about 4 questions we have time for. And I want to say thank you to all the healthcare workers on the front lines over the last year. It's been a tough year. And I mention that because one of our questions is from a clinical social worker who points out that Medicare is currently unaffordable for most of her homeless and near homeless clients due to patient copays and restrictive rules of coverage of chronic mental illnesses. She asks, why call our goal Medicare for all rather than healthcare for all? And I guess there's a note here, not sure if the expansions of behavioral health coverage solve the problem of providing for chronic and severe mentally required for coverage. And this person says, I hope so. So that's the first question.
Sure. It's a great question. And I think it really highlights what I think is one of the hardest parts in terms of the messaging. Like I said, Medicare has been around for a long time. It's overall seen as a very successful government program, reliable, et cetera. But absolutely, the way that it's structured as of now, like I mentioned, there's no out-of-pocket cap. That's ridiculous. The coverage that has for mental health is not great. And so definitely that's why it's important to highlight that it's definitely not Medicare as is for all. No one's advocating for that, but a very improved Medicare for all. That being said, I think that there is an importance in being specific, because if we say healthcare for all, I bet there's a bunch of Democrats right now who would claim that we have healthcare for all because we have a bunch of different programs. There's Medicaid, there's Medicare, there's the marketplace, there's employer plans, and that there you have your pick of choice, and that there's healthcare, right? The point of using Medicare is that we're implying many things. We're saying we want a federal program, right? So this is not state-based. This is a federal program, so that one, it's a national network of providers, and that it's public. And so I think, obviously, again, like I'm not saying it doesn't have its deficits in terms of the messaging, but that's why then we have to do these things like teach-ins and et cetera, and making sure we're making it really clear that I completely agree with everything that this clinical social worker has said, or that this person has said that was pointed out by a clinical social worker, and say that that's what Medicare for All recognizes. We recognize that people right now, especially for people who are experiencing homelessness or near homelessness, do not have access to the care that they need, that a lot of times it's absolutely unaffordable. And that's what Medicare for All recognizes, and wants to deliver comprehensive mental health care without copays, private insurance premiums, and deductibles.
Thank you. Next question. A physician points out that Medicare for All faces substantial hurdles from medical industry lobbyists, voter resistance to eliminating employer and other private plans, and to tax increases. He asks if we can consider more moderate plans like the European models that maintain employer payments and supplemental private insurance as more politically practical alternatives.
So, I mean, I think in a single payer system, and I can't think of any single payer system around the world that doesn't still have like an employer contribution to it in a form of some type of tax. And so I think like that would actually still be there. And also the supplemental, I mean, Medicare for All does actually allow supplemental for benefits that aren't covered. I think if we're talking about duplicative private insurance, or benefits that aren't, that are benefits that are covered by Medicare for All, let's say, and that you would allow private insurance to do that. I think that's like the German model. The German model does that. Basically, everybody has a government insurance that's actually administered through private insurers. And if you have a certain income, then you can elect out and go into like a private insurance plan. That's the German model. The thing about the German model is couple things. I mean, one is they started this almost a century now ago, right? Many, many decades ago, before the private insurance system was able to become very entrenched. So they've been able to regulate this to a level that I just do not believe is possible in the US. The other piece of that is that what they're seeing is that there's actually this inequity happening between people who have the public insurance and people who have the private insurance. There's longer wait times for the people with public versus private, access to services, et cetera, right? There's this all German. So there are private plans that are available in Germany, privately administered, and say for profit. So privately administered. But I think what we're saying between there is that there's this sort of tiered system that's happening depending on what plan you have, and that's the point of single payer. Single payer is literally the most equitable way to do this, and so if the goal is just to get people more coverage, then sure, like there are other avenues that are less ambitious than single payer. But if the goal is truly centered on equity and justice, then single payer is truly the only policy solution that I have seen. And honestly, private industry is going to hate and fight public option just as hard as they are for single payer. And so, I mean, that's sort of my argument against that. But I think, there's a historical context, there's like a systems context that exists for European models that I just don't think can be replicated here.
Thank you. I'm going to ask a third question, and Cheryl will ask a fourth question. We have about 2.5 minutes per question, so we want to make sure we hear all of your responses to this. So the third question is, several people asked, what can we do to make a difference this year in moving Congress to expand Medicare benefits and coverage, and to give our states like Washington State, our state, the support we need to achieve universal health care plans for all our residents?
Yeah, it's a great question. I mean, definitely, I think is everyone in District 7? No, right? I assume not. I think this is across the state of Washington.
Correct.
Well, there are people in the Washington delegation who did not sign on to that letter for expanding Medicare. And so if you noted them, let them know that you noticed. And let them know why it's important, why they need to be seeing this moment. Same thing with the Medicare for All bill, same thing with the state-based universal health care bill. Everyone, you can either go to the Congresswoman's website to see the letter to see who signed on, or you can go to congress.gov to see who has co-sponsored those legislations. And I think just making the case really clear, I think absolutely the fact that there is going to be an established Universal Healthcare Commission makes a really compelling case. And you want to tell your Congress members they should, be connected with what the state wants. The state passed this. It's obviously what the direction they're heading, and they should keep up. And always be willing to share your stories. I think the way you message things, though, like I mentioned earlier, is just really critical. You want your emails to be readable. I promise you, staffers are getting 1 billion emails a day. And so the easier your email is to read and the ask is very clear, the easier it is to respond. And so always please reach out to your offices. They are resources, but be mindful of communication because there's a lot going on.
Okay. Okay, thank you. Senator Murray and Representative Pallone are publicly seeking input on what a federal public option might look like. What features does Representative Jayapal think a public option would have to include to make it a real step towards Medicare for all?
Sure. I think this is, an exercise the Congresswoman and I had to do last summer when she was chairing the Unity Task Forces set up by then President-elect Biden and Senator Sanders, because again, it was just very clear. The directive was Medicare for all is not going to show up in this list of policies that Biden's going to support. So what can we do that captures tenets of that? And I just want to make it extremely clear the Congresswoman much more prefers single payer. She absolutely sees the flaws that exist within a public option. And so just particularly answering to this question, and just to be direct for that, I think in order for a public option to be remotely okay to be considered, or be a considerable step towards Medicare for all, is one, it's similar to what I'm talking about for Medicare expansion. It has to be through CMS, it has to be through Medicare, right? If we're creating a whole new public plan, and if that public plan is allowed to be administered by private plans, we've defeated the purpose. You're not getting the savings, and you're just creating more fragmentation to the system. The Congresswoman absolutely believes there should be as little cost sharing as possible. She would absolutely prefer zero. But as little as possible, no deductibles, as small as copays as possible, and as subsidized as possible. I mean, premiums should just really not exist at all in terms of the insurance premiums. But I think depending on where they are, I think for the task force, I don't remember quite well, but I think it was up to 400% federal poverty level. It would be a $0 premium. I have to check back on that. But I think those are just sort of those key tenets, right, that we've talked about before, where it would have to be public, non-administered by private, and as limited cost sharing as possible. And the benefits would need to be comprehensive.
Thank you. Thank you so much, Stephanie Kang. We learned a lot, and we also just feel empowered by your leadership and your inspirational talking points. I think we go into this next year wanting to fully support these two legislative acts in Congress, and also just keep pressuring the Washington State delegation, which I'm hearing is a priority, so we can get them all to sign on to the current legislation. So I think that's all for now. We're gonna
do you mind if I just make a quick comment?
Oh yeah, please do.
Yeah, I think there's a reckoning that has to happen within communities. And I'm just reading some of the comments, and I understand people's frustrations. I understand where people are coming from, and I just want to just be really clear, especially when it comes to physicians. I mean, that's literally the history, right? I'm not talking about every single physician. I was specifically pointing out the AMA and the role of other medical providers, but they're literally the reason why. We didn't have a national health insurance program in the 40s. They tried to block Medicare and Medicaid. They tried to block the integration of hospitals. And so I think, just being honest with that history and recognizing that and being able to move forward is really important, I think, for the movement, and also for us to be able to engage. It's not meant to be a criticism. It's just truly like, that's what happened. And so how do we move from there? And how do we, if we're going to talk about health equity, because AMA will talk about health equity every day, that post things about it. But let's be honest then, and let's be able to say, what do we really mean when we're talking about that?
Thank you for addressing that. All right. We may want to do a teach in part 2 at some point. So there's always more, and we hope we'll be seeing you again and covering what could be the next steps after July. All right. I'm going to introduce now Ann Vining, who's a staff attorney who works on health policy issues at the Northwest Health Law Advocates. And she's going to be speaking about the Medicare Cliff and state options to address the Medicare Cliff absent federal action. So thank you, Ann.
Thank you very much. This is really a brief introduction to this idea about the Medicare Cliff. And that term came into use because it refers to a big disparity between affordability and programs for people with Medicare compared to the Affordable Care Act programs, which I know problems with those too. Affordability, a lot of people that haven't experienced this don't know about this disparity between Affordable Care Act programs and Medicare programs. So Medicare Cliff refers to that big drop in coverage and in subsidies that happens when people go on to Medicare. I know many of us are pretty excited about the possibilities of different expansions, but it's really important to really understand why the Medicare program isn't comprehensive and isn't at all affordable for many low and moderate income people. So here's the effect. AARP, in their most recently published report on the topic, shows that low-income Medicare enrollees, 200% of poverty and below, the median, so half of them, and spent 27% or more of their income on healthcare. Women and racial ethnic minority groups are disproportionately affected because they're more likely to be in those lower income categories. Somehow, a lot of people think that Medicare's free, and that's probably because most people get premium-free Part A based on their work history. But Part A is just one piece of Medicare, and premiums are just one type of cost. And you see the result is there's an awful lot of people paying too much for healthcare. So this is an example. I have a couple of examples that kind of show this. This person we'll call Martha has income of a little over $1,000 a month. It's actually just a little over the federal poverty level. She has modest savings, given that she no longer works and she wouldn't be able to replace it if she has to use it for an emergency. She has moderate health needs. So here's what happens. Before she's 64, she doesn't have Medicare. Her income is low enough to qualify her for Medicaid, the Affordable Care Act expansion Medicaid, which we do have in Washington. But when she turns 65 and she gets Medicare, she's disqualified from the ACA programs. You think, can she get Medicaid? Well, no, because the Medicaid program for people who are aged, blind, and disabled, including anybody on Medicare, has different eligibility standards, much lower income. And then you think, well, but what about, subsidies for premiums and cost sharing and stuff? Well, there are programs for that. But even with her tiny income and low savings, she doesn't qualify for any of the Medicare savings programs that do that. She does get a little reduction in her prescription costs because she qualifies for partial low-income subsidy. The result is she's got $320 a month of costs compared to nothing before she turned 65. And she doesn't have as many services as she had on Medicaid. Probably the worst is she has $867 a month left for housing, food. You can see that's tough. So here's another example. Jorge also has Social Security income. His is a little higher, more like a more typical Social Security income, a little over $20,000 a year. That's 156% of the poverty level. A little higher savings and moderately high health needs. Before Medicare, at age 64, he has too much income to qualify for Medicaid, but he can purchase a qualified health plan on the exchange, and under the Affordable Care Act, he gets subsidies. His premiums are subsidized right now because of COVID relief, giving extra subsidies, the ARP Act of 2021. They're like $7 a month. Because he has moderately high health needs, we're assuming that he would have expenses that go up to the cap that's available. And adding that up, he was paying about 12% of his income for healthcare costs. But when he gets Medicare, he doesn't qualify for the qualified health plans. Medicare disqualifies you. So then you look to, well, what programs are there for people on Medicare? The aged, blind, disabled programs. These are programs that date back to the 60s, in concept, when people who got assistance basically were destitute. He doesn't qualify for any of them. He's too rich. So what happens to his costs? Well, assuming it's the same 27%, which is the median, it's $452 a month. There's no cost cap in Medicare. This is just a chart, a series of charts that kind of compares it. If you look at the column on the left, that's what applies to people that don't have Medicare, that can get Affordable Care Act programs. The middle column is what happens for people on Medicare. And as you go up, you're talking about higher income people. So the purple field at the bottom, the age blind disabled Medicaid, the only one you can qualify for if you have Medicare, requires income of 75% of the poverty level. That's $814 a month in Washington. Affordable Care Act, you can have 138% of federal poverty. The brownish colored one in the middle is when you can get help with both premiums and cost sharing. And on Medicare, that's the QMB program. You can see it doesn't even go up as high as the Medicaid program goes on the ACA side.
2-minute warning.
Thank you. They're over on the ACA side, that goes up 250% of poverty. Compare orange. This is for people who get at least premium subsidies. And for that only goes up to 100% of poverty for Medicare beneficiaries. But on the other side, it went up to 400%. And then with the expansions, Washington is considering it would go up higher. And with the COVID relief, it's basically unlimited. So the column on the right is, gee, we could do this. Federal law allows states to expand Medicaid and Medicare savings programs by raising those limits, and federal funding shares the costs. 34 states have done this. They've done something, not parity, but something. Washington has not. We have a website. It's not quite built, but it will be by the time you get the slides. There are links in the slides where you can get our detailed report with research and more information. There's also a link to give us feedback if you support this, if you have a story about struggling on this problem. And if you want to send an email to me with a question, or you're interested, you or your organization is interested in engaging further on this, let me know, ann@NOHLA.org. And thank you very much.
Thank you so much, Ann. That was an informative presentation. I'm betting several of us know people who are struggling with healthcare costs who are on Medicare. So this is a widespread problem. So I'd like to introduce now Steve Bauck. He's the Vice President for Outreach, Puget Sound Advocates for Retirement Action. He's going to be speaking about the issues Medicare Advantage plans present for enhanced Medicare for all and some ways to lessen their impact.
So when we think about Medicare for all, most of us picture federally funded and administered plan of health insurance, but the reality this year on Medicare is 42% of enrollees are actually on subsidized private plans. And that percentage is projected to go up to 50% by 2025. As we look to fight for Medicare for all, we have to deal with the reality of Medicare Advantage. There are a lot of issues that individuals have with Medicare Advantage plans, and I'm not going to get into those. There's racial justice issues, there are care issues. I want to focus instead on why Medicare Advantage plans are attractive, how they've been able to make a profit and expand, and what we can do to minimize their advantage. So when people are faced with a decision of what they're going to do in Medicare, they'll get a lot of brochures for Medicare Advantage, a lot of publicity, and a lot of people don't even they just sign up for something, they don't even know whether they're on Medicare Advantage or not. But for those who do pay attention, there are some really attractive parts of Medicare Advantage. And Stephanie covers some of this already. One, there's no cap on Part B expenses under traditional Medicare. That's essentially all expenses except drugs and hospital. Medicare Advantage plans do have a cap, as does every other form of health insurance. There's no drug coverage under traditional Medicare. You have to buy a separate plan under Part D, which usually has high deductibles and may or may not have high payments. Medicare Advantage plans provide drug coverage, most of them with minimal copays and often no deductibles. There's no coverage for dental, hearing, and vision under original Medicare, except for what's deemed to be medically necessary dental surgery. Medicare Advantage, as Stephanie said, doesn't include full coverage for any of those things, but it does include many of the programs, very substantive benefits in those areas. And they're able to do that and make a profit, substantial profit, and yet they have 18%, almost 19% administrative costs versus traditional Medicare's under 2% administrative costs. So the issue is, how is it structured in a way that allows that to happen? So Kaiser Family Foundation did a study in 2016. They looked at people who had been on traditional Medicare in 2015, and they compared those that switched the next year to Medicare Advantage and those who stayed on traditional Medicare. They went back then and looked at their usage in 2015 when both groups were using traditional Medicare. They found that those who switched to Medicare Advantage used a lot less health care. And it's not because they were necessarily healthier. If you adjust for age, gender, and chronic condition, the disparity is still there. In fact, the greatest disparity was for those that had the most chronic conditions. And you can see in King County, that disparity amounted to $2,000 per enrollee, right up front profit for Medicare Advantage plans. A part of that is because they will include things like gym memberships to attract people that are more physically active and taking care of their health. And they are strategic in where they advertise, what markets they go into to try to get people, not necessarily ones with fewer chronic conditions, but ones that use less healthcare. Now, recently, the Office of Inspector General has done some audits of some Medicare Advantage plans, and they're going to be doing a lot more in the next year. And what they found is basically fraud. Medicare Advantage is funded totally different than traditional Medicare. Each plan gets a monthly amount based on the county they serve, and the base rate is based on the average cost to serve people enrolled in traditional Medicare the year before. That rate is then adjusted for the particular individuals in the plan. And one key factor is the risk coding of individuals. When you sign up for Medicare Advantage, often you'll get a nice, pleasant call from someone wanting to come visit you and do a home visit to help you keep healthier. One of the things they're looking to do in that call is find reasons that they could upcode you to a higher risk code. It doesn't do anything to give you more care. It just gives them a higher payment for any service for serving you. And what the Office of the Inspector General found is that consistently programs couldn't document the high risk codes they were using for Medicare. Now, there's another factor here, and that is that Medicare Advantage plans, the data, all their data is proprietary. They don't share that with Center for Medicare and Medicare Services, so that they can use this high risk code to get payment from Medicare. But when they go then to pay a provider, they use a separate lower risk code and therefore pay the provider less. You can see in 2015, this audit estimated that there was several $1 billion that were lost this way from Medicare. You can see that the percentage is down at the bottom. That's not for everyone in those plans, but it is for the ones who are in the audit who are very high risk coded people, 140% overpayment. So another area is denials. And there again, the HHS Inspector General issued a report they found that on appeal, 70% of Medicare Advantage denial claims were completely overturned and another 5% were partially overturned. The key factor is that only 1% of claim denials are appealed. Now, the ones that are most likely to be appealed are the ones that are most likely to win, but even taking that into account, there's no downside for denying claims for Medicare Advantage. They just have to pay the claim. But they get a huge benefit when people don't exercise that right to appeal the claim. And as you see in the statement there, that Medicare Advantage beneficiaries and providers were denied services and payments that should have been provided. Now, Medicare Advantage plans have a cap on how much they can earn, but all in addition to that goes into additional benefits, which makes the plans more attractive, which continues to erode traditional Medicare. So what can we do? And these are, so first thing is allow negotiation of drug prices, which allows the money to be able to do some of the other benefits that's needed and provide a drug coverage benefit under fee-for-service Medicare. Every other form of health insurance has a cap on co-pays and deductibles. That has to be a part of fee-for-service Medicare as well. And as Stephanie said, adding dental, vision, and hearing benefits. So to get around the proprietary data of Medicare Advantage plans, require all Medicare Advantage claims to be submitted to Center for Medicare and Medicaid Services so that there is transparency, and deal with the denial rate and put some cost on the unwarranted denials. Finally, if people are on Medicare Advantage and decide to switch back to traditional Medicare, there's no guarantee that they can get a Medicare supplemental plan. They don't have, only in 3 states are they required to be provided those. Washington State is one of many states that does have a community rating, which means everyone pays the same rate for medical supplemental, but you don't have, if you're bid on Medicare Advantage, you may not well be able to get a supplemental plan. So those are some of the things. There are a lot of other things that can be done to lower the advantage of Medicare Advantage. We have to address that if we're going to move ahead on Medicare for All.
Thank you, Steve Bauck.
Healthcare is a Human Right has partnered with 2 students, Lacey Russell and Hannah Swanson from the Tacoma Community College's Community Health Bachelors of Applied Science program. For the final capstone project of their degree, they developed an important organizing tool for us called a PowerMap. And we're excited for them to demo it for you. Lacey and Hannah, take it away.
We're really excited to show you the great measuring tool that we have developed with HCHR. This past May, we began sending out email invitations to HCHR member organizations and allies to participate in a brief survey, asking them to share their contact information and organizational abilities within each congressional district. These data actively help us to gauge grassroots support for our coalition across the entire state of Washington. Help us work more effectively to generate public pressure when and where it is needed, both for our shared coalition priorities and also in solidarity with the member organizations' particular campaigns. It is important to note that the following demonstration is not of the live website or of actual proprietary information. It's simply a mock-up for our public presentation today. If you direct your attention to the centermost column of the slide, you will see a screenshot of what is the homepage of the PowerMap site. Underneath the HCHR logo is a color-coded map of Washington State, divided by current CD boundaries. By clicking on any individual circled CD number, you will automatically be routed to its corresponding CD page to view its information. The following slides will demonstrate what information is provided in each CD page. Next slide. By clicking the circled 1 on the home page, you will be directed to the CD1 tab, such as this, as shown across on the top of the page. Susan Delbenny's page will be our examples a day. From here, there are several great interactive things you can do. By clicking Representative Del Bene's official photo, directly routes you via a new browser tab to her GovTrack site. Clicking the underlined District 1 shown will do the same. The pop-up box shown is provided just for this meeting to show a simple visual of what the hyperlinks lead you to. GovTrack data shows excellent aspects of the representative, which include ideology, ratings from advocacy orgs, their organizational memberships, bills sponsored, enacted legislation, and voting records.
Hi, everyone. So moving down the page, we see drop pins to the right of the individual CD image cutout. These pins represent organizations that have reported any presence within this particular district. Now moving to the left of the CD image, you'll see organizational ability. And by clicking this text, a new browser tab will open. Next slide, please.
2-minute warning.
This tab is a spreadsheet of organizations that have filled out their survey in order to be featured on our PowerMap. Based on information they have provided, we have created the spreadsheets to list the org name, org point of contact, and their position, approximate number of total members, email and phone number, and a rough estimate of their presence in that particular district. Many orgs are listed more than once within the entirety of the PowerMap, no more than once in each CD. This is to reflect that their org is present in individual districts. Next slide, please. Finally, at the very bottom of each CD page, you will find the official logo of every organization that has self-reported to the HCHR survey. By clicking any of these logos, a new browser tab will pop up, leading you to their official website. HCHR would love to feature as many organizations on this PowerMap as possible. So if you are present today and have not yet completed the brief survey or have not received it, please contact hchrwashington@gmail.com for further information. And a huge thank you to those that have participated thus far. It is very important to be united in the fight for equitable healthcare. And by adding your org to this map, we are further enhancing our united front, creating a database and visualizing our strength in numbers. So with that, we will pass it over to Nathan Rodke for specific calls to action, and we appreciate your time.
So thank you so much. I'm Nathan Rodke. I work with Washington CAN, and I am on the Healthcare and Human Rights Steering Committee. I'm going to introduce our calls to action for the night. We've got 3 of them. The first one's the most nuanced, but we do have it here on the screen for sharing. I urge folks to write it down. I think we might be able to get into the chat as well. And if not, I've already started typing something to put into the chat, so you can copy it from there. But what we want to lay out is a little more, well, actually, Stephanie laid it out in really great detail, so I'm just going to hash over it once again. The first one is getting our members of Congress consistent with their support for HR 3 in 2019, again in 2021. Again, what Stephanie said was the U.S. House passed a bill in 2019 already that has all of this in it, the prescription drug negotiations and lowering the Medicare age to cover more benefits for everyone on Medicare. And this is a really great thing that we want to achieve. So we need the House of Representatives to go ahead and pass that bill again in 2021 when it's not so easily just going to die in the Senate. So there's 2, you did hear that over 150 members of Congress signed on this letter. There are 2 representatives that we really think should be on it that are not, or who should be supporting it, that did not name their support in that letter. So we're urging you, if you are in Kim Schreier's district, that's Congresswoman Kim Schreier, that's the 8th Congressional District, or Susan Del Bene, Congresswoman Susan Del Bene in the 1st Congressional District, to call the number listed on the screen there, 202-224-3121. And the message is support policies in the May 27 letter from 155 House reps to President Biden regarding prescription drugs and Medicare expansion. And I'm almost finished typing, and I'm gonna put in the chat too. So I'm gonna get that in the chat so that everybody can just copy it from there as well. There we go. Thank you. Okay. So the other piece of that, as you can see in the chat, the message, it's as clear as we can really make it because it is pretty nuanced, but support policies in the May 27 letter from 155 House reps to President Biden regarding prescription drugs and Medicare expansion. The letter goes into more detail, and all of these staffers, they're very well aware of that letter. So I don't think you need to worry about being more detailed. But for everyone in our audience across the state, that message is good enough for Senators Patty Murray and Maria Cantwell as well. They have both laid out their support for Medicare negotiations, but we really want to make sure that they're getting really solid and being positioned really solid to also support Medicare expansion. So we want to have that in there. Before I get too deep into this slide, I want to make sure that we're really clear here. We are also supporting HR 1976. So as far as that one goes, that one is the Medicare for All bill that has been prime sponsored by Pramila Jayapal. The same number is on there. And for those of you who just want to write it down, I'll even put it in the chat here, HR 1976. And I'm actually going to go in reverse order here in how I describe this one, because there is no Senate bill yet for everyone to make the call to Patty Murray and Maria Cantwell. Just ask them to support companion legislation for HR 1976. I want to make clear that there is a bill coming. Senator Bernie Sanders is going to introduce a bill. It just has not been introduced for 2021, but it will be the companion bill in the Senate for Pramila Jayapal's Medicare for All Act of 2021, the Improved Medicare for All Act. Now, shifting focus to our House reps, as you can see on the screen, Susan DelBene from the 1st, Rick Larsen from the 2nd, Derek Kilmer from the 6th, Kim Schreier from the 8th, and Marilyn Strickland from the 10th have yet to co-sponsor or publicly state that they support the Medicare for All Act of 2021 or Medicare for All in general. So we want to continue to put the pressure on them to let them know how important that is. And then you can see it on the screen there. It is also consistent with the state-based Universal Health Care Act. So finishing up on the Medicare for All one, if it is consistent for Smith and Jayapal, they're both either prime sponsors or co-sponsors of both of these bills. So if you call them on any of these bills, it's to thank them for their support or leadership. But as it goes with the rest of our members of Congress, for both of these bills, we want them to co-sponsor. We want them to become co-sponsors of the Medicare for All Act. And then the one you see on the screen, this one is it's the one I really want to get a little more in depth on, but we've already talked about it a little bit. This is consistent with the state creating a statewide universal health care commission and committing to covering everyone in the state. If we can get the waivers to make that process easier, we could do it a lot sooner than 2026 or beyond. So we really want to have a chance to get those waivers. So again, ask your reps for this one, for the state-based Universal Health Care Act. It is HR 3775. So you ask them to co-sponsor HR 3775, and that's to, again, Susan DelBene, Rick Larsen, Derek Kilmer, Kim Schreier, Marilyn Strickland. Call 202-224-3121. Finally, we are going to send out a really in-depth newsletter in the next few days that is going to have everything I just mentioned and a lot of other info that will be kind of rehashing everything we went over today. If you don't receive that newsletter as of right now, please email hchrwashington@gmail.com to ask to subscribe. That's hchrwashington@gmail.com. And I spelled it correctly and it's in the chat. So we would love for you to become a subscriber to the HCHR newsletter. And yeah, that is our calls to action for the night. I get the duty and privilege to hand it off to Claude Burfect. Claude is a very prolific organizer and an amazing organizer, and a new member of Healthcare as a Human Rights Steering Committee. And he has been working diligently to set up a forum, a legislators forum for August with state legislators and federally elected members of Congress and senators. So I'm going to pass it to Claude to give us more background on that. Thanks, everyone.
Well, thank you. Thank you. Nathan, on that spiel on phenomenal organizer. What I have done, I just got back from my sister's funeral yesterday, and I have been working vigorously and hard before that. And I've been working with Marvin Ng of Adam Smith's office, along with Rachel Bergstrom of Jayapal, Pramila's office. Now, what I wanted to do was to make sure that Rachel had the date set. We will do this in August between the 9th and the 12th of August. That is when Congress is on an extended vacation, the whole month of August, unless something happened that they have to be called back to Congress. So we will have put together a congressional forum, and we also have some legislators that we have on board as well, that Senator Frock of the 46th, Macri, Representative Macri, Senator Kaiser, and Senator Randall. Now, I had also spoken with David Loud that I would need a little bit of assistance on getting the legislators, but before we can do that, we have to have a date set for the forum that we are going to put together. What I've also done was, we know Congresswoman Jayapal, we know that Congressman Adam Smith, and I've also contacted Marilyn Strickland. I'm also in touch with Susan Del Benny, Kim Schreier. I don't want to deal with Rick Lawson because he is not with the program, but Derek Kilmer. And so I think we will have anywhere between 4 and 5 of your congressional folks on board. Now, we can ask those questions. We can make sure they sign on to HR 3775. They can co-sponsor, but I will have those folks on board. I will give you the exact date either tomorrow or the day after tomorrow, the exact date that we will have this event. And from there on, we can get all of our legislators together so that they can be the ones saying, we are supporting this, we are supporting this legislation. What about you? What are you doing to support healthcare as a human right? So we will have that event scheduled between the 9th and the 12th of August. I promise that. And we will have it one of those days, and I will let you guys know exactly what day we will have it, either tomorrow or day after tomorrow. But it will become a fruition. And I will have at least 5 congressional leaders on board from the state of Washington, so we can ask the questions and put them on the spot. Make sure that they are supporting the bills that we are asking them to support. That's it for me.
Passara is having a Juneteenth event, not on Saturday, Juneteenth, but on Thursday. The Art of Grace in the Face of History, with storytelling, poetry, and music celebrating the rich heritage. 6 o'clock on Thursday, Puget Sound Advocates for Retirement Action.
Second announcement is that we, being a labor community coalition, we want to be supportive of some of our sisters and brothers from labor. Two are running in SeaTac, the city of SeaTac, the birthplace of the minimum wage movement, and currently has a Trump-dominated city council. So we're letting folks know that we're going to be working out there in the community, door knocking for two candidates from labor, Jake Simpson, Unite Here union organizer, and Edith Guzman, who is a social worker in the Tyee High School, which is part of the Highline school system. She's a Highline Education Association member, and Mohammed Egal. So we're encouraging folks to come out and door knock with us June 26th. It's the link for registering is in the chat.
NOHLA is holding a more in-depth program on the Medicare Cliff on July 15. We will put that in our information in the newsletter.
Okay, thank you, Margaret. And thank you everyone for joining us this evening. And I would like to thank our presenters for the work that they do, because it is important to our end goal. I would also like to thank everyone on this team who put this evening's event together for their hard work. And I would especially like to thank those of you who gave the time to attend this event. Thank you all.
Thanks, everybody. And just a reminder that stay tuned for action alerts, newsletter coming out as indicated by Nathan. And yeah, Cheryl and I are gonna start our chant.
Okay.
Everybody unmute yourselves. Unmute yourselves.
Unmute.
No healthcare, no justice.
No justice, no
Healthcare,
peace.
no justice.
That's right.
No healthcare, no justice, no justice, no peace.
That sums it up right there. Thanks, everybody. The new word for 2021. No justice, no peace.